So today it's about antiplatelet therapy post-PCI, and I just can't get away from that DAPT duration issue. And these are the correct disclosures for me. Importantly, I'm part of multiple trials that looks at dual antiplatelet therapies post-PCI. So the subject of this talk is antiplatelet agents, and it's vast, and no one wants to see any more, I think, hopefully, Plato and Triton and prasugrel and clopidogrel slides. But I will give you some of that because I think it is important for everyone to just review the differences between these three agents that we use so frequently in our armamentarium after PCI. So very different antiplatelet agents, yet with the same focus of inhibiting platelet aggregation and enhancing outcomes, not just within the stent, but also beyond the stent for the patient. And you see that both prasugrel and ticagrelor have a quicker uptake, more potent, and they're much more reliable in inhibiting platelets, but it is important that the majority of our patients are on clopidogrel, and there is that combination with aspirin as well. But it is important for you all to know that of these, ticagrelor is the only reversible agent. The other two are irreversible, and the time of onsets and the duration of effects are incredibly important. I also think it's important to note of the new kid on the block, the intravenous antiplatelet therapy, cangrelor, which is a direct P2Y12 receptor antagonist. It's a non-thienopyridine, just like ticagrelor, and it has a very quick onset and offset. And in the Phoenix study, it was associated with a reduction of death MI and stent thrombosis within 48 hours. It was seen very early in the first 2 hours. And then, of course, stent thrombosis being really an important reduction, especially intra-procedural events, which are usually not measured in most of our trials. But let's get to the meat of this talk, which is about duration of dual antiplatelet therapies and what we need to think about as physicians. I start with the safety and efficacy of prolonged DAPT because most of us after the DAPT study were sort of, well, does this mean we've got to give DAPT to the patients forever? And I think the answer is probably no, and that we really do have to make an important judgment call. There are lots and lots of trials that look at this duration, the different durations after stenting, and the evidence review is there to tell you that if you prolong dual antiplatelet therapies, you will have lower rates of stent thrombosis and myocardial infarction. And this is important, and it's always been the focus for us as interventionalists. We put in the stent, we don't want it to thrombose. So we give dual antiplatelet therapies, and if we prolong it for a while, we're able to reduce stent thrombosis, the stent that we as interventionalists put in. But when you prolong DAPT, you expose patients to more bleeding. So if you reduce the duration of DAPT, you can have a lower risk of bleeding, no question about that. And that was also seen from 12 to 36 months in the DAPT study, where you could have a significant reduction in bleeding, but also maybe all-cause mortality, which is very interesting. Difficult to show the causal relationship, although more and more data are coming in that if you expose patients who don't need dual antiplatelet therapies to a prolonged duration and cause bleeding as a result, you can have a major negative impact, which is mortality. And one of the first people who's really noticed that was Sunil Rao sitting here, and he's been using bleeding avoidance strategy and has been an incredible partner on this ride of really, really judicious use of dual antiplatelet therapies and all of our regimens that cause bleeding. And that trade-off is an important one. We constantly do this in order to make our important recommendations and judgment when we take care of patients. This bleeding ischemia paradigm that we continue to think about. In the meta-analysis that we published, we did a back of the envelope and we did do the calculation. And what we did find that for every stent thrombosis event that you avert when you prolong DAPT, you are causing 2.1 extra clinically significant bleeding. So that's your calculator that you need to figure out. Where does your patient fit in when you make those decisions? And this is an important, if you do it across the board, this is what you're doing. If you're not thinking, if you're just looking at the papers and listening to, maybe a drug rep or whoever saying prolonged DAPT on everyone. Not one size does not fit everyone. And why is that? Because bleeding matters. We've got to think about bleeding. Here's data from a DAPT DES showing that if you look at bleeding versus myocardial infarction, here it is, post-discharge bleeding, after the patient leaves the hospital and you're not seeing them, you're not there to quickly take care of the bleeding episode, versus the post-discharge spontaneous myocardial infarction that we're so worried about and try to avert by giving dual antiplatelet therapies. The hazard of post-discharge bleeding is 5 compared to 1.9 or 2 compared to the spontaneous myocardial infarction. So it is really, really important to think about bleeding. It matters, and we have to make an important judgment about that. It is also important to note that the previous studies that looked at these prolonged DAPT had a conglomeration of stents, first and next generation. And what do we know about the next generation DES? If we actually pull out the newer generation, like everolimus-eluting stents, we found a significant attenuation of the risk of stent thrombosis with shorter duration of DAPT in those patients who received the second generation DES. So if you're really looking at stent-related activities, you're not going to make a very, very big important impact if you prolong DAPT to reduce the stent thrombosis you're worried about. And in fact, in the DAPT study, when you pull out the everolimus-eluting stents, which was 4,700 of those patients, you did reduce stent thrombosis, but look how much wider the confidence interval is and how close it comes to the line of unity. And look what happens to the major adverse cardiovascular and cerebrovascular events. It's no longer significant. And of course, bleeding continues to be a gift that keeps on giving. And also, mortality is in the wrong direction for those patients. It is important to think about the kind of stent you're putting into the patient. And one size does not fit all. We shouldn't walk away from this and say nobody gets prolonged DAPT. In fact, you do have to think in your heart, what am I really treating? Is it the stent or the patient? And I hope it's the patient. And so we have to look at the patient in general to make those important decisions. And now there are calculators. There are 3 such good scores. The DAPT score, if a patient has tolerated 12 months and now you need to make a decision, you can use the DAPT score. At the time of PCI, if you're worried about thrombosis versus bleeding, you can use the Paris score. In an ACS patient where you're thinking, what should I do? How can I precisely figure out, especially for bleeding issues in ACS patients, then you can use the precise DAPT score. These are all available online, and I urge you to think about that. But at the end of the day, I think it's not about scores. The scores are as good as if we use them. And how many of us have time to do the Timmy score, the Grace score, the this score, and the that score? And I've written a lot of scores. And I'm thinking at the end of the day, let's just look at the patient. And Deepak Bhatt did a really nice job in putting this, I think, this schematic together about the patient-related factor, the anatomic-related factors, and the stent-related factors, and putting that together. And it's a real, common sense sort of a schematic that tells you about the patient's presentation, their comorbid conditions, the number of stents you put in, what kind of anatomy do you have, and you can make an important decision really in a very, very logical manner. Let me tell you that there are newer stent technologies that are coming on board, the newer metallic stent technologies that are coming on board, looking at the high bleeding risk patients, because we still, a good majority of our patients do have a risk of high risk for bleeding. And how do we make those decisions? If we're going to shorten it, do we have to use a specific type of a stent, or can we work with some of the newer generation DES to shorten the duration of dual antiplatelet therapies? One such stent is this drug-coated stent, the BioFreedom drug-coated stent. It doesn't have a polymer. It has surface modification for drug delivery. And in the very large 2,500 patients compared to a bare metal stent, there was a reduction of course, target lesion revascularization with 1 month of DAPT. In fact, this stent was associated with a reduction of the ischemic endpoint as well. And as a result, there's a major program ongoing in the United States for this patient population in a single-arm study. Other single-arm studies is the Evolve Short DAPT study with 2,000 patients receiving the Synergy stent based on some data that showed that perhaps this biodegradable polymer can have an important impact. We've also known a lot about the fluoropolymer of the everolimus-eluting stent Xience, and we have so much data on so many different areas, and we'll have that during the lunch session today. But finally, we have a short DAPT trial in focusing on patients receiving the Xience stent. These are patients at high bleeding risk where the duration will be cut down to 3 months, and hopefully we can move to 1 month at some point. But certainly this is ongoing. The first patient has already been enrolled, and many, many sites are being recruited into this study. I can't walk away without talking about the approved bioresorbable scaffold. So far, the current trials put in for 12 months. We know that this is a first-generation device, and we also know that there have been some issues with late stent thrombosis, so the optimal duration is not known, and if your patient is tolerating it and received the BVS, I would continue to survey them quickly for bleeding issues and watch them. Now, for the very master file of how you could make a decision, the guidelines try to do their very best in making this very, very simple to make you go through this. Acute coronary syndrome patients, everybody gets class 1 indication for 1 year, unless there's some bleeding issue. Afterwards, you make a decision after a year based on bleeding versus ischemic risk. On the stable ischemic heart disease, you really have multiple choices, right? You have CABG, which there's very, very little data. There is PCI and CABG, and right now it's been shortened down to 6 months. Hopefully we can move it even closer to the 3-month zone. Finally, I also want to tell you about trials that are withdrawing aspirin. And, of course, this one is the one that I'm leading, the TWILIGHT study, complex patient population, CHIP types of patients, multiple stent, with or without ACS, in whom you believe that a more potent agent like ticagrelor and aspirin would be beneficial. At 3 months after they've tolerated that 3-month zone of aspirin and ticagrelor, we withdraw aspirin in a double-blind placebo-controlled fashion. We've already enrolled 6,700 patients in these 9,000 patients and have randomized close to 4,000 patients in this study, and the study is ongoing. And we're waiting for this trial, the Global Leaders Study, where 16,000 patients have already been given only 1 month of dual antiplatelet therapies with aspirin and ticagrelor, and then aspirin has been withdrawn in those patients in that experimental arm versus the standard of care. So there's a lot to be learned, and I know that my time is up, and I wanted to just quickly, if I can, touch on this particular area, the oral anticoagulant therapy, the major conundrum that now brings in not just stent thrombosis, but stroke. And now we know that the oral anticoagulants are better than dual antiplatelet therapies for stroke prevention. And we also know that dual antiplatelet therapies are better than oral anticoagulants for stent thrombosis aversion. What what's a girl to do is what I say, because it's mostly girls that treat this, right? No. But what is an interventional cardiologist who has a patient who requires oral anticoagulation to do to prevent stroke and to prevent stent thrombosis, but avoid bleeding because it could be catastrophic? Well, these guys, the Worcester investigators, said, let's get aspirin out of the equation. In about 600 patients, they took aspirin out. They exposed everybody else to aspirin, Coumadin, and clopidogrel, and they showed a reduction in bleeding, but also a reduction in an ischemic endpoint. Small study, but very, very interesting. It gave us a way to start to think about novel oral anticoagulants, and when we put in Xarelto in the equation and put in a Worcester arm that has Xarelto and clopidogrel alone versus a Atlas arm that has Xarelto, clopidogrel, aspirin versus the standard of care with Coumadin in the Pioneer AF study, we showed that both of these arms with Xarelto were associated with a major reduction in bleeding complications, significant bleeding complications. I don't have time to tell you that it also reduced hospitalization and death, and there was no difference in the ischemic outcomes, but again, underpowered study. So you can use the novel oral anticoagulants in a very good way to reduce bleeding. There are several ongoing studies here for novel oral anticoagulants, and you see them listed here. Pioneer is done. Redual will be presented, I think, at ESC. Augustus and Entrust obviously underway for all of these different trials. So there's a lot to do, and certainly this is from Dominic Angelillo. Bleeding reduction strategies is something we've got to be thinking about all the time. And of course, in this population, you use the lowest dose of aspirin, you minimize DAPT duration, radial access for all, of course, clopidogrel over prasugrel or ticagrelor. Novel oral anticoagulants can be a choice. We only have data with Xarelto so far, and certainly keeping the INR pretty low. Thank you so much for your attention, and sorry to go over time.